again, good morning, welcome back. You're watching WHCC TV. I'm Mabel, Jong. Thank you so much for joining us, and we're going to continue our coverage of the conference with an interview with Dr. Craig Samitt, who you may remember was with Anthem, and now is here as President and CEO of Blue Cross Blue Shield Minnesota. Good to see you.
Good to see you as well. It's good to be back.
How do you like your job so far?
It is awesome. I've been in the Midwest before. I was the CEO of Dean Health System in Madison, Wisconsin, and I've always been a believer that the upper Midwest will be one of the leaders in driving the transformation of value-based care. So I'm back in the Midwest, despite the cold, and doing wonderful, fun, transformative work at Blue Cross Minnesota.
Fantastic, but you do feel that the pace of reform is not happening quickly enough.
Yeah, I love coming to these conferences. They give me both this unique combination of hope and frustration all at the same time. I was called by a friend of mine from my Harvard Pilgrim days a few weeks ago, and she asked if I was still irreverent, and I was taken aback, and I'm like, irreverent? Is that a slight? And I realized it's a compliment.
Like, oh, okay.
Well, I just think that I'm impatient and I'm frustrated with the pace of change to value. I counted that it's my 25th year advocating for transformation to better care at a lower cost, and while I'm seeing glimmers of hope, I very much would love to see us make more progress.
What is the holdup? I mean, there definitely seems like people who get it and are trying to make the moves towards reorganizing their organizations, but it's taking a long time.
You know, I'd say that it's probably two things. One is, as I reflect on my many years doing this, I believe we're good at one particular thing in healthcare, which is we're good at admiring our problems. The issues that we struggle with in healthcare today, whether it's our service orientation or lack thereof, or the unaffordability of healthcare, or really the focus on the profitability of sickness, so to speak, versus the profitability of wellness. We keep talking about this as the problem, and I'm not sure the incumbents in the industry, those of us who have been doing this a long time, have been forceful enough or brave enough to pursue a lot of change. So I think that's the bigger issue. I also, hearkening back to my years on MedPAC, I think one of our biggest challenges is value-based payment. I think you get what you pay for, and we're taking baby steps toward risk-based payment and really a model that is accountable. And we have to move faster, and we have to be more aggressive in that pursuit as well.
What piece is still left out? I mean, with the technology is there, we certainly have all of those pieces in place. So what else is needed?
I think the greatest thing to fear is ourselves. I think it's fear of risk. You know, I think everyone owns the problem. One of the things that I'm very attentive on in Minnesota is we own pushing the providers more to value-based payment. That is our challenge. I don't think we've been forceful enough, and some would say that plans haven't even been willing to share risk or change the payment model. I think care delivery is as much a problem in that we're addicted to fee-for-service healthcare, and there are a lot of uncertainties about making the pivot to something that is more population health focused.
Okay. Any advice on that, what that recipe looks like? If an organization wants to make the move aggressively as you are trying to advocate for, what do you want to see?
I would say there are three things we need to do differently. One is we need to, at least on the health plan side, as well as on the provider side, be willing to enter into risk-based arrangements and value-based payment models. We may even want to say at some point certain, at some date certain, fee-for-service healthcare goes away, and that we need to sunset a volume-driven, margin-driven model and focus more on something that truly looks at better quality through lower cost, not the reverse. So that's the first thing. The second ingredient, I think, is what we call provider enablement. We on the health plan side, if providers are going to accept value-based payment, need support. They need the data, they need the care models, they need to understand what clinical model best practice is. That's the third thing. And then I'd say the second thing. The third thing that I would say is we may have to be comfortable stepping out of our lane. And what I mean by that is we'd love to find partners, care delivery partners that wish to transform to value. But if we can't find enough, we may need to get into the care delivery business. Again, health plans have been there before. Maybe we need to become the change we want to see, so to speak.
Okay.
That if care delivery isn't reinventing ourselves, we come up with a new model, or we invite disruptors into our markets to change healthcare if care is not changing itself.
Well, there is that saying, if you want something done well, just do it yourself.
Perhaps. And I've spent my whole career fostering payer-provider partnerships, so I'd rather lead with a partnership. But what happens when a partnership is one-sided? If we still want to drive change, we may need to do it ourselves, as you say.
The sunset date, how much time then, if we're going to say adios to something, how much time are you going to give people to
I
do
don't
that?
think we have a lot of time. Rising costs in healthcare are unaffordable. You know, a lot of the reason why we're talking about Medicare for all and why we're concerned about the stability of the Medicare Trust Fund and every indication that we can't keep going this way suggests that time is limited. So I think that if we don't change ourselves from the inside out, someone will change us from the outside in. And Medicare for all aside, I'm even more worried about the disruptors. Amazon, Target, Walmart, Google, Apple, that look at healthcare and say, it's not very service oriented, it's hard to use, it's inaccessible, and it costs too much. Maybe we should do what we do best from other industries and bring them into healthcare. So I don't think we have a lot of time to drive the change. I would say I would love to see us reinvent ourselves within the next 5 years.
You've been pretty critical of organizations that call themselves ACOs but may not truly be. Can you point to an example of it that you like?
Well, actually, I'm heading into a panel shortly with Presbyterian Health Services. The organizations that I know and love are the Geisingers of the world, and the deans, and the healthcare partners, and the Presbyterians, and there are shining lights of examples that are true ACOs. I've been critical because I actually find it a bit insulting that so many organizations are calling themselves ACOs, when I believe that unless you're in the top quintile of quality while also in the lowest quintile of cost, you don't get to count yourself as an ACO. The whole point of ACOs was to deliver on the real promise of better care at a lower cost. There are some great organizations that are doing it. The problem is we haven't scaled it. We need it everywhere. We need it in every market. And right now, only patients, only members in certain signature or distinct markets get access to true ACOs.
Okay, Dr. Samitt, it's always great to see you here.
Good to see you as well.
What keeps you coming back to the World Healthcare Congress?
As I said, I'm always hopeful when I leave the World Congress because I see so many innovators and so many people who want to change. I think there are many people here who are going to lead the transformation. I just want us to get on with it.
Well said. Thank you so much.
Thank you very much for having me.
And thank you for watching. Stay tuned. We have many more interviews to come.